What I would like to do in the next 20 minutes is talk about scaling education broadly, meaning across the spectrum of learners, from patients to practicing physicians, and broadly in terms of geography, that is globally. I'm a pediatrician by training. I do pediatric infectious diseases. And before my current role, I served for 10 years as the Senior Associate Dean for Medical Education at Stanford. And a lot of that activity was focused on medical student education, which I'm happy to talk your ear off about in terms of the problems we need to solve. I also had responsibility for residents, fellows, and continuing medical education. But about a year ago, I convinced my dean at the medical school and the provost of the university to allow me to develop a new center at Stanford called the Center for Health Education. And I now serve as a senior associate vice provost for the university for this center. And the center is a combination of two resources on Stanford campus. One, shown on the left, is the Stanford Office of the Vice Provost for Teaching and Learning. So I am happy to be surrounded in that office by individuals who are dedicated to trying to figure out how, as educators at a university, we can do better and what resources we can leverage to make things better. And many of those resources are in technology, innovation, digital learning. And it's an office that has about 200 people of various different talent sets to help solve the teaching and learning issue. And I still remain, of course, a member of Stanford Medicine, my home school at Stanford University. One of the first projects that we developed, actually even before the center was established, to try to figure out how to deliver education was something called Digital Medic. And Digital Medic is an acronym. Digital is not much of an acronym, but MEDIC stands for Medical Education International Collaborative. And we call it digital because it is digital. And we call it the international collaborative part because it is our feeling that if we are to share resources and aggregate resources on a global stage, we must do it to be effective in collaboration with local learners, local teachers in different parts of the world. So I'd like to share with you in the next slide a brief video about what Digital Medic is. Before going there, a picture of the world, improving world health through education, innovation, and collaboration. And what I like to express, which I think will resonate with each of you, is that education empowers, health education saves lives. This is a little bit about Digital Medic.
Billions of people worldwide struggle from avoidable disability and death because they do not have access to adequate health care. A key reason is that there is a shortage of health workers being trained worldwide. The World Health Organization estimates there is a global deficit of 7.2 million health workers today. Unless action is taken now to modernize and advance global medical education, this deficit will double by 2035. To address this health worker crisis, the Stanford School of Medicine has launched the Digital Medical Education International Collaborative, Digital Medic for short. Digital Medic is working to make Stanford's healthcare education content available to anyone, anywhere, anytime. Stanford Medicine consistently ranks among the top U.S. medical schools, and faculty members have a long history of achievements in healthcare, education, and research. Sharing this expertise requires a new approach to how healthcare education is developed and delivered. Using the latest learning technologies, the Digital Medic platform provides courses that are digitally enhanced, customizable, and learner-centered. With interdisciplinary expertise in medicine and online learning, the Digital Medic team has created the initial infrastructure needed to scale this initiative for a global audience. The team has already begun collaborating with partner institutions to co-create content that addresses the most pressing knowledge gaps in medical education. The content is designed with the learner's culture and healthcare needs in mind. To reach millions of learners worldwide, Digital Medic will be available to end users for free indefinitely. With this strategy, Digital Medic has the potential to transform the landscape of medical training and reverse the global health workforce shortage.
So when I initiated Digital Medic, I must say, and the images would suggest, that I had the median learner, at least on this picture, in mind. I've spent my life in an academic medical center working with medical students, and that was sort of the sweet spot of our School of Medicine. But I have learned in the ensuing couple of years that, to the point made earlier by Javid, democratizing healthcare, and another point made earlier by one of the other deans, which is task shifting, we have to pay attention to the entire spectrum of those whom we need to educate. And that spectrum includes the patients at the far left-hand side of this arrow, the patient's family, who I'll mention in a moment, programs to use the family members as an extension of healthcare delivery, community health workers, who I believe now are much of the solution of delivering healthcare to our most disenfranchised, most populated areas in the world, through other healthcare professionals, with the medical student in the middle, and then moving to the right to our more advanced learners who are residents, fellows, faculty, those who are primary care doctors and specialists and super specialists. But I believe that the greater part of the solution is on this end of the curve rather than that end of the curve. I don't think we can build enough medical schools in the world to actually accommodate healthcare without the partnership of the patients, their families, and community health workers. One of the central tenets of what we're trying to do in the Center of Health Education is to build programs for certain kinds of learners and then expand them to all of the other kinds of learners. I'll use some of our nutrition education as an example of that in consideration of the spectrum that I've just described. So in this picture, this relates to nutrition curriculum. One of the leaders of the curriculum development is a highly talented speaker, an animator who is quite impactful in delivering digital content. Her name is Maya Adam. And Maya has created public-facing, massive open online courses for teaching the general population about nutrition. They're hosted on Coursera and edX, and this slide is a little bit old because there's about 250,000 individuals who have taken this course to learn for themselves more about nutrition. We've repurposed that nutritional content, and the 16,000 learners is actually those persons who are learners in rural communities, principally in Africa and India, where the nutrition education is the same facts, but it's repackaged so that those learners can understand its relevance to their particular circumstances. We've also got an instance of that curriculum for medical students. And you can see we've got 188 learners that have taken that. Compare that to 200,000 learners in the general population. And we've built a continuing medical education course around nutrition with the same facts. I mean, the facts are the facts, but repackaged for the particular kinds of learners. And I've learned as we've tried to mature our center and our programs that a lot of the focus where we should be spending our time and effort to make the biggest impact is at the community health worker level. As I'm sure you're aware, in most parts of the world, community health workers, who are generally poorly educated individuals who are often part of the local community, but are dedicated to the local community, they get taught some basic knowledge that they then convey as positive deviants in their community to their fellow community members. Bill Gates, when Gates Foundation did an analysis of where their money, and it's a substantial amount, is best spent to see a return on investment in health outcomes, has concluded that community health workers are the best value for the dollar, the largest return on investment. So one of the programs that we're doing to try to demonstrate that we can make a difference at the community health promoter level is to develop a flexible platform which we put onto tablets, content that is used by community health promoters. They're called mentor mothers in this particular nonprofit in South Africa. The tablet-based education is used by the mentor mothers to go to the townships, to sit with their clients, and to explain nutritional concepts, in this case for pregnant women. In these under-resourced areas. We've built an app that can be loaded and is loaded onto smartphones so that they can also deliver the content in that way. We provide both the tablets and the smartphones to these individuals to go into their communities. This is a picture when I visited South Africa in March of this year. This is the woman in the middle, is a woman who has run this organization, a nonprofit called Polanis, which is in rural Cape Town. She's a Swedish physician who has run this operation for mentor mothers for the last 30 years. Maya Adam, I've referenced, is the other woman. And the women shown on the top are mentor mothers who are coming to be trained in how to use the tablet-based education for their clients. We're doing a randomized controlled trial that just launched in this organization to demonstrate whether or not tablet-based education, enhancing the approach to these mentor mothers, results in learning outcomes as measured by, it's a breastfeeding platform we're using, or a breastfeeding content area, whether the outcome as measured by duration of breastfeeding is better when it's tablet-based versus the old-fashioned way, which is basically reading from a syllabus, and many of these women are not literate. We'll have the results of that in about 1 year. I also strongly believe, as I'm sure most of you do, if not all of you, I hope, that educating patients is part of the democratization of healthcare. Educating patients. So I mentioned the nutrition curriculum for educating patients, and another one, that initiative that we have, is trying to educate women about the value of breastfeeding. Again, in my visit in March of this year, we launched in South Africa a 100% breastfeeding campaign. Shockingly, in South Africa, and true in many of the other African countries and other countries in the world, the frequency of breastfeeding, especially exclusive breastfeeding, is very, very low. In South Africa, it's estimated to be less than 10%. There are a number of factors which contribute to that. It is a real problem. It's estimated by the WHO that over 1 million infant deaths globally result from an absence of sustained breastfeeding for the first several months of life. So we wanted to start the public campaign in knowledge about breastfeeding through this launch. One of our poster children, quite literally, for the breastfeeding campaign is the little girl shown here. She is from the village that I mentioned, the township called Polanis. She was exclusively breastfed for 6 months, and I think you can tell, even if you're not a pediatrician or a parent, this is a healthy-looking child. When we launched the breastfeeding campaign, we decided to reach the public through some celebrities, and this very brief trailer will give you an idea about the messaging that we're using to try to convince the population of new mothers in South Africa that they should be breastfeeding. The 3 women that you'll see, this is one of them, are celebrities in South Africa. We decided that why would you want to listen to a white, gray-haired man from the United States? I'm Canadian, by the way, just if anybody wants to talk politics. Why would you listen to such a person as opposed to listening to local people, especially those who are well-known? This woman is actually the lead singer of one of the well-known, not to me at the time, but rock groups in South Africa called Freshly Ground. The other two women you'll see in this video, one is a former Miss South Africa, and another is the wife of the captain of the Australian national rugby team. We felt that people would listen to them because they're recognizable and they're passionate about breastfeeding.
I had very big plans for feeding my baby both times.
It always made sense that I was going to breastfeed her. Before she was even born, I knew that.
I'm really looking forward to breastfeeding my daughter. I'm expecting a girl.
I believe that if I breastfeed my child won't get sick.
Lucky that my mother knew these things. She was a domestic worker. She knew certain things not to give a child at certain age.
I grew up in a township. When I had a baby, I suddenly remembered actually how many women gave their children formula instead of breastfeeding.
Fathers are especially important in the supporting role in the household.
If you can breastfeed your baby, please do.
If you breastfeed your child will always be closer with you.
The first choice for my baby.
The first choice for feeding my baby.
My first choice for feeding my baby.
The first choice for feeding my baby.
First choice for feeding my baby.
I apologize that the movement on the film was off from the soundtrack, but you get the point. So this campaign was just launched in March. Of course, our metrics for outcome is the proportion of women in South Africa who begin breastfeeding and have sustained breastfeeding, especially during the first 6 months of life. And then the final audience that I'll mention in this talk about whom we should be training, well, the second to final, are family members. So I had never thought about the role of family members as extensions of health provision. And it was only through a couple of our medical students at Stanford with an engineering student and a political science student who went to a program at Stanford at the D School, which stands for the Design School, and the program was about design for extreme affordability. The D School was established by the founder of IDEO, by the way, David Kelly. And these students decided to build something that they thought would have an impact on health outcomes. And what they built was a nonprofit called Nura Health. And Nura Health is based upon a simple premise. And the premise is that some of the persons most vested in an individual's health beyond the individual are the family members. And that these family members in parts of the world where health resources are limited could serve as an extension of the healthcare system. And so their model was to develop digital videos, and this was in India, using Bollywood actors at a very good rate, actually, to develop educational content on tablets that they would then educate the family members about their loved one's illness, and that family member then would help to transition their loved one out of the hospital and take care of them back in their local communities. And so they developed this program called Nura Health. This is a picture of one of our medical students, actually in the middle, and the founder is the guy in the black shirt, Shahed Alam, who decided, actually, he just finished medical school this year at Stanford and made the very difficult decision, instead of going on to his residency, to return as CEO of this company in Bangalore and to continue expanding Nura Health's footprint. Their Q1 results this year show that they have reached now about 200,000, almost 200,000 family members in training. And this doesn't show the outcome metrics, but the reduction in rehospitalizations for some of the diseases they were treating was up to 70%. The reduction of post-operative wound infections for that part of their training in post-surgical training was about 70% as well. This is empowering family members to be healthcare providers in those countries. So again, back to the point that Javed made about democratizing healthcare, I think we will only accomplish that when we can educate the patients, work with the family, train community health workers, and yes, I still deeply care about the training of medical students. And the last picture that I'll have, and there's the medical students circled. This is an article which I just published with a colleague, Tao Li, in a journal called Academic Medicine. I'll take you to the bottom line of this particular article, which was about developing a singular curricular ecosystem for medical student education in the United States and globally. And we said a shared core curriculum could begin to bend the cost curve of medical education in the U.S., but also scale internationally to help address the increasing global shortage of healthcare workers. Why should every country in the world or every medical school in North America develop its own instance, for example, of an anatomy course? Anatomy is anatomy is anatomy. We don't have to keep spending and respending resources to develop a course where the core knowledge is agreed upon. And I could say the same about some of microbiology and some of biochemistry and much of cardiology. Yes, there's a need through international collaboration to make sure that the content is adapted for the local environment and the local diseases and the local culture, but sharing will allow us to begin to democratize medical education and truly make an impact in terms of dealing with dramatic healthcare disparities. I thank you very much for your attention.